So final presenter for this session. I have to be nice to you because you're a client. So Mathew Cherian, Group Managing Director of Global Health Limited. So a little bit different to some of the other presenters today. Mathew has over 40 years of software development experience, and he actually transitioned Working System Solutions, a company he founded in 1985, from a bespoke software developer into an IT consultancy across multiple industries, into a focused healthcare software company renamed in 2008 to reflect this focus as Global Health Limited. Please welcome Mathew. Thank you.
Thanks, Josh. And thank you, everyone, for giving me the time to listen to our story. While you absorb the weasel clauses or the disclaimer, a little bit about the history of the company. We started, as Josh said, contracting, building software coming out of Perth. I guess it was mining companies, technology companies, finance systems, hospitality, and so on. And our first foray into health was in the early 90s when we had the recession we had to have. And a lot of the multinationals actually pulled out of Perth. So an American company that was given the task of building PAS systems for hospitals wrote a check and pulled out of WA. And that's when a smallish company like us got the opportunity to do our first system for WA Health Department, which is a PAS system for rural and regional hospitals in WA. So in the early 2000s, Working Systems was awarded a contract by the Australian Capital Territory to develop a mental health solution. That's been the driver for us leaving our non-health business and focusing purely on health. So one of the drivers, there's lots of things that are confronting healthcare. Any of you watched the Q&A yesterday? There's talk about lack of GPs, lack of psychologists, lack of attention on women's health, and lack of funding in general. So there are two drivers that influence our thinking in healthcare. The first is the unsustainable escalating cost of healthcare, which is quite simply because there's better technology that allows us to detect our conditions earlier, better technology with devices. I mean, I've been to a few of the presentations today, and I'm amazed at the amount of new stuff coming out in healthcare, both in terms of pharmaceuticals as well as devices. And this is becoming unsustainable. But most importantly, 70% is spent on managing people living with lifelong conditions. And this is what's driving us as well. The increasing incidence of chronic disease or lifestyle diseases. I know genetics plays a role in whether you have a propensity towards diabetes or a mental health condition, but so does our behavior. And this is something that's universal. The whole world's got this problem of a sedentary lifestyle and the increasing incidence of chronic disease. And it's costing a lot to the health system. So that's what drives us. Our mission is to improve health outcomes for patients and improve and drive the cost of healthcare down. $200 billion is spent in Australia on health, as my previous slide showed, and that doesn't include the NDIS, right? And there's probably another $10,000 a year that we spend on health-related purchases, whether it's a gym membership, whether it's a diet food, whether it's vitamins. So you've got $200 billion spent on health in Australia, $200 billion on the NDS, and God knows how much more on a personal expenditure basis. It's a huge problem that needs to be solved. So that's our vision. We have 4 platforms. Our first involvement in mental health occurred back in early 2000s. And as you can tell from the previous slide, sadly, mental health issues are 2 of the 5 most common, anxiety and depression. And the risk factors that cause these diseases are often our behavior, tobacco use, obesity, wrong foods, not enough exercise, high alcohol usage. So these are all preventable causes of this escalating cost of healthcare and impacts on us. We also have an aging population. So all the factors are pointing to the fact that healthcare needs disruption. And that's what we're all about. And because our first system was in mental health, we recognized that people living with lifelong diseases need a team of different skills. So we have a GP, we have a psychiatrist, we have a psychologist, we might have some social workers, we'll have a call center that all get involved in helping me change my behavior or deal with the fact that I'm suicidal or have anxiety or depression. And what we realized was that it was very paper intensive, as I'm sure you guys know. There's a lot of rekeying. In fact, 35% of the cost of healthcare, of the 200 billion or 250 billion that we spend, is not spent on patients. It's spent on administration and rekeying of data and all that sort of stuff. The stuff that's not patient-facing. So that's why we recognized and built this portfolio of SaaS platforms, which basically deals with the clinician side. So Mastercare is our brand that's deployed for clinicians, regardless of where they work. In the case of people living with mental health issues or diabetes or hypertension, your encounters in healthcare can be across multiple delivery settings. It could be in a clinic, it could be in a super clinic center, a community health center, it could be in a hospital, it could be at home. But Mastercare gives the tools necessary for the team of different skills to work together as a team with me, the patient. And I'm not aware of any other system in Australia that does it, that has one, as I like to say, one throat to choke, where we have the full suite of systems that cover consumers, because I am part of the care plan. I have to change my behavior if I've got diabetes or high blood pressure or a mental health issue. And I've got a team of carers working with me, and there's no other system I'm aware of that has this structure of a team-based group of clinicians working in collaboration with the patient. The fact that there are silos, that everyone's got their own system, allied health might have a system, a GP will have a different system, a specialist might have a different system, was the reason why we built end-to-end encryption with a secure messaging platform, which we call ReferralNet. And we are one of only 3 vendors in Australia that meet the requirements of the Department of Health to send discharge referrals, orders, results, progress notes, and so on, from one clinician to another in a secure manner. I had a project in Malaysia, and I had to get Defence Department approval to be able to ship ReferralNet into Malaysia some years ago. And finally is our digital front door. We used to call it a patient portal. We used to call it a digital reception, your online reception desk. But the consultants in healthcare came up with the term digital front door. I don't know how many of you have heard of that term, digital front door? Okay, so good. So that's basically where you engage with the patient, either for forms, proms, pre-admission forms. You do video consults with patients, between clinicians and patients. It could be done one-on-one or one versus many or many and many. You do discussion groups, forums. You do online, appointments and all that sort of stuff. So it's everything you need that avoids the need to rekey data. So we're capturing data at the source once and passing it through to the whole team of carers that need to know. Now, bear in mind that our initial applications in healthcare were built 20 years ago. So the bulk of our revenue, our business as usual, comes from our older style technology, which is often referred to as on-prem, but really it's a structure which is not SaaS. For those, everyone knows SaaS, software as a service, so it's where you have multiple tenants in the cloud that can be provisioned and use this product quite easily. It's like Xero or anything like that. So we have spent a lot of time migrating our 20-year-old products into a SaaS architecture. 4 SaaS applications that cover the patient journey from initial diagnosis through to treatment and through to, rehab, and probably for the rest of your life. Because people living with chronic diseases tend to have, it's not facility dependent. Most of our competitors would be, we write software for a hospital, we write software for pathology, we write software for GPs. Ours tends to be software for people living with lifelong conditions, which is 60% of the Australians, right, of Australians, and probably worldwide that figure is not that far off. Because of that, we have deployments in multiple locations. Hospitals, chains of hospitals like St. John of God, Mercy, individual hospitals like St. Andrews or Bethesda in Perth, community health centres, the government, like the West Australian Mental Health Commission. We also have Department of Justice, Department of Prisons. So our product tends to be deployed across many, many different sectors. And that gives us a huge competitive advantage because we're not stuck in a particular sector. We can pivot quite easily. So for example, most of you would have read about the pressures on the private hospital systems. The insurers are not giving them enough money to cover the cost of delivery. And so they are in strife. We've lost about 3 or 4 hospitals because they've gone broke. So we were able to pivot very quickly into the secure messaging field. We were able to pivot very quickly into the community health sector, which a lot of our competitors can't do because they're stuck to a particular use case, if you like. Moving on, I'm going to just talk a little bit about our expenses. 2022 was the first year out of COVID, and the results reflect that inability of our customers to earn money. But more importantly, and the reason I make the distinction between R&D, EBITDA, and EBITDA after R&D is because R&D, or in our terminology, is growth R&D, is investments in products that are going to earn us money tomorrow, not today. And what we saw was an urgent need to fast-track the migration of our old applications or our mature applications into the SaaS platforms, which we did. So you can see that we turned around our EBITDA before R&D quite significantly over the last 24 months, growing 25%, I think, our revenue, and keeping our expenses down. Now, if you move to the R&D side, you'll see that in 2022, our R&D spend was very low. We cranked it up quite significantly in 2023 from $340,000 to about 1.7 million. And last year it was up to 2.7. And that's all self-funded. So the money we were making from our operations was being reinvested for tomorrow's growth. And the reason why we are fairly keen on transitioning our products to SaaS is because right now we have 3 different applications. Primary Clinic is for primary care, GPs, allied health, and specialists. Mastercare PAS is for hospitals, and Mastercare EMR is for team-based clinical care. But I'm very happy to say that this year would be we've started to transition our clients from the old mature platform into the SaaS platform. So instead of having to support 3 different platforms, instead of all the hassle of onboarding new clients, in a SaaS platform, it's all done with very low touch. So this is almost finished, and we've already started rolling it out to some of our clients and getting some new clients as well. Looking at the revenue side, similarly, despite having to spend a fair bit of money on product development for tomorrow's revenue, we were able to grow the revenue by 25% in the last 2 years. And our ARR, or annualized recurring revenue, which tends to be the measure of valuations for SaaS companies, has grown by 17%. It now represents well over 70% of our total revenue. The rest of the revenue tends to be professional services for training, rollout, bespoke development, integrations, and that sort of stuff. So our net revenue increased 64% from 2.8 to 4.6, which is subscriptions less cost of goods sold. And our cost of goods sold, this is a term that people define differently. Our cost of goods sold is every cost associated with servicing a revenue stream. So that's support people, it's maintenance developers, it's all the platforms we use for Zendesk, for Atlassian. It's all third-party components that we license within our products. So the gross margin is being a healthy 56% last year, and our goal is to bring it up to 60% this year. I think the SaaS gross margin is probably closer to 80%, as you'd expect, or 90%. So I want to now talk a little bit about the market. Because our focus on chronic disease is independent of the delivery setting, we are able to address a wide selection of the Australian healthcare market, whether it be hospitals, specialists, as you saw from our customer list, community health centers, primary care, which is GPs and allieds. Basically, you don't need a referral to present to a GP or a physio. And finally, the consumers. And this is the part that I think excites me the most. Because every industry that gets disrupted, seriously disrupted, that disruption is driven by consumers. We are the ones who decide to book online, to buy online, to get a taxi online and so on. And in healthcare, that is the huge opportunity that that's going to disrupt it quite significantly. So within the consumer market, we haven't yet monetized LifeCard. We have well over 400,000 LifeCards out there, but we have not monetized it. We're not charging consumers for it yet. Because like any other application in the cloud, consumers don't pay for applications. The plan is to monetize it through other means, and I'll get to that in a minute. So looking ahead, this year, we have started the rollout of migrating our customers from the on-prem versions to the SaaS. And I've got to say, the incidence of cybersecurity and privacy breaches has helped our cause. Most people are quite happy to say, look, you host it, Mathew. It's on Microsoft Azure and Amazon Web Services, Amazon. So these are, credible global players that give us access to a global market. So we're actually on both Amazon's and Microsoft's global marketplace. So this year we will be rolling out Mastercare SaaS to our existing customers as an upgrade. And we're starting to sell our Hot Health digital front door and our secure messaging to our existing customers. Currently, I'd say those additional applications represent less than 5% of our revenue. So there's a lot of capacity to land and expand, if you like, with our digital front door and our secure messaging. We've also initiated new campaigns using digital channels to acquire new logo clients. I mean, don't forget we spent a lot of money on R&D last year, but this year we've cut the R&D expense down to $2 million, so we've got a bit more cash to be able to spend on growth. And our target this year is to cut our expense by a further 10%. So beyond this financial year, which is going to be line ball in terms of operating cash flow result and profitability, we're looking to the next financial year to be able to start monetizing LifeCard. And we do that by working with partners who can provide content, value add, marketplaces, gym memberships. The money that we spend on healthcare broadly can be monetized. And we're not going after the consumer directly. We're going after the consumer via our existing B2B customers who are servicing millions of customers. So it's basically a B2B2C play that we will be pursuing going forward. We will also be looking to develop reseller channels. I mean, healthcare is a universal product. If you've got diabetes, it doesn't matter whether you're in Turak or in Timbuktu, the treatment plan is the same. If you've got high blood pressure, if you've got depression, anxiety. So potentially the growth will come from moving into export markets. And our initial goal is to work in economies that are underserviced, where the clinician-consumer ratios are a fraction of what they should be. So these are countries in our neighborhood, Vietnam, Indonesia, Thailand. We're staying away from the more developed economies like Singapore or Western Europe or North America because they tend to be churn markets and very competitive. But the underserviced markets in our neighborhood are our initial target to sort of expand our SaaS portfolio into overseas markets. Just a bit of information on the company. As Josh said, I started Working Systems and we listed in 2000, and it was too good an offer from the brokers that I couldn't refuse. But we listed the week NASDAQ crashed, so it's been a bit of a tussle since then. And pivoting to the health, exclusively to the health sector, has been a really exciting move for us. I still have 40% of the stake. You can tell our market cap, our enterprise value is probably less than our last 12 months revenue. And we have a very strong and loyal base of shareholders. So the top 20 hold about 80%. So it's very easy for the price to move one way or the other. I think earlier this year we had one of the investment funds have a lot of redemptions, so they had to keep selling stock, and they did at 9, 10, 11, 12 cents. But since then, we've managed to break through a little bit, and we hope to break through a lot more going forward. Finally, we have a good, strong board that are all passionate about what we're trying to achieve. They've all come from a history of healthcare. Grant Smith, in the 80s, corporatized hospitals. So he worked for an insurance company who bought private hospitals and then eventually exited, selling it to Maine Nicholas, I think, and who then had to sell it to HealthScope and Ramsay. So he's got, 3 decades or 4 decades of involvement in hospitals. He still builds hospitals. We have Steve Pint, who's our compliance, legal, and conformance representative on the board. He's a very practical lawyer, I have to say. So he's not about writing copious amounts of thick contracts. It's a practical contract. Stephen Strange started a aged care software business, which was dominant in residential aged care. And he then sold to private equity, and he's on our board. So he's got a software background as well. And he will help us move into the adjacent market because we understand that we have an aging population. We're all living longer. Karen was a consultant with KPMG, I think. And she did a lot of work consulting to the public sector. So she sat on board at Cabrini and Peninsula Health and so on. So she has a public sector dimension to our business. And so we have a very productive and supportive board of directors as well. And it's there to be, I've listened to a lot of presentations the last couple of days, and I thought, my God, my story is a lot simpler, right? We don't have all the hurdles that the pharmaceutical companies and the device manufacturers have. We will get those hurdles once we introduce AI into our platforms. And that's why our strategy in terms of introducing AI is to work with partners that have done the hard work and got the TGA approvals and so on. And Microsoft and Amazon are helping us with that effort as we speak. So hopefully by June next year, we'll have some AI in our applications as well. I think that brings me to an end. You can have a look at our website, look at our product descriptions, and I'll take questions. I might leave it on that slide.
Thank you so much for your presentation. I found it really interesting, particularly, as you said, you're B2B and then B2C. What I'm curious to know, the slide that you had with the triangle, so the consumers down the bottom, the influence, who you're selling to, is it influenced by the insurance or the practitioners? So I'm just curious to see if there's a roadblock with insurers or not.
There definitely is a roadblock with the insurers. I mean, I think about 2008 when the government reduced the restriction on private health funds to just hospitals. They allowed private health funds to fund non-hospital care like allied health or ancillary care. We sponsored an insurance conference like this, and I was quite excited. I was trying to tell them about the tsunami of chronic disease that was coming ahead, but they didn't want to hear. All they wanted to hear was how they could reduce the payouts to hospitals. So yet they are the biggest beneficiaries. The funders of healthcare are the biggest beneficiaries, because if we get, as individuals, if we change our behavior and live well longer or avoid getting into situations where we need hospitalizations, then the funders, which are the state government, the federal government, and the private health funds, are the ones who benefit. But getting it across to them is a bit more challenging, so we tend to sell to the providers of the services. One of the advantages we have is that the Australian health system is quite unique. Most of the other countries, like UK has got the NHS, Canada has got Infoway, New Zealand's a single funder, and the single funder is the HMO. But we have a very complex funding system. So we have federal government supporting some of it, Medicare supporting some of it, private health funds supporting some of it, and every state supports the public hospitals. The Commonwealth supports non-hospitals, and the state governments support the hospitals. And then they have special programs like Headspace, like all kinds of, there's about 20 or 30 different funding programs. So, so the customer, being the service provider, are the ones we sell to because we support all those funding programs. So we can help them get their money. Yeah?
What geographies do you currently work in? Is it only Australia where your revenues come in? And if so, what percentage? You mentioned which ones you're targeting, but are you only operational in Australia at the moment?
At the moment, yes, it's just Australia. Yeah. We are talking to resellers, so I don't think we'll ever open offices overseas for a while. But we do want to work with resellers who understand the local market. And that's why we've got 4 platforms rather than 1, because we can work with competitors rather than have to say you've got to throw away your, your hospital system if you want to use our system. We'll sit on top of their hospital system, both locally and overseas as well.
Okay, well, please thank Mathew again.
Thank you.